So this is one of the questions which was asked: diagnosis and treatment of the deformity given in the picture below. So I think it's a very straightforward question, and the answers, I mean, though not the ideal answer, but there are options given are hallux varus and metatarsal osteotomy, hallux valgus, Akin osteotomy, hallux rigidus, Keller's operation, and hammer toe and arthrodesis of MTP joint. So I mean, if you look at it, the we know that this deformity is actually a hallux valgus or a bunion, and the treatment for that is ideally a metatarsal osteotomy, not only an Akin osteotomy. However, since the question asked has only one option with hallux valgus, so then I will put hallux valgus and Akin osteotomy. But in case this option was hallux valgus and metatarsal osteotomy, and the second was hallux valgus and Akin osteotomy, then I would have marked this as hallux valgus and metatarsal osteotomy, which is actually an osteotomy which I would recommend in such a case. So, just talking about hallux valgus, I mean, we know that this is a hallux valgus deformity. So, what are the questions that can be asked in this? So, first of all, it's a radiological measurement that they might ask for. So, there are certain angles that we always calculate in the hallux valgus. So one is an hallux valgus angle, which is an angle between the long axis of the first metatarsal and long axis of proximal phalanx. The normal angle is not less than 15 degrees. So an increase in the angle would suggest a hallux valgus, and you always compare it with the opposite side. Then another angle is an intermetatarsal angle, which is between the long axis of first and the second metatarsal, and the normal angle is less than 9 degrees or less than 10 degrees. And an intermetatarsal angle means that the deformity is a little bit more proximal, and you should go for a more proximal based osteotomy or first TMT joint. The third is an interphalangeal angle, which is between the interphalanx, which is between basically the proximal and the distal phalanx. Normally, this angle is less than 10 degrees, and an increased angulation means that the patient would get benefited from an of the proximal phalanx, which is the Akin osteotomy. And the another one is a distal metatarsal articular angle, which is also less than 10 degree, and it basically tells the direction of the articular surface of the first metatarsal distal aspect. So in this, what you do is you draw a line which is which is basically along surface of the metatarsal, and one line which is along the long axis of first metatarsal. So a line which is perpendicular to the long axis of first metatarsal and a line between the articular surface, you measure the angle between them, and this angle is normally less than 10 degrees. So if the angle is increased, we call it a congruent hallux valgus, which means that the articular surface is actually shifted outwards, and it is actually congruent with the proximal phalanx. The joint is actually congruent. There is an increased distal metatarsal articular angle. Then, whenever you're doing an osteotomy, you so factors which are related to hallux valgus: genetic, ligamentous. Genetic is the most common. Associated with pes planus is very common. Those who ligamentous laxity or are hyperlax, rheumatoid arthritis, gout, as well as any shortening of the second toe, which can be either due to a brachymetatarsia or an amputation, can all risk development associated with development deformity is which two box and which are high valgus pressure. Uh, operate, I think, not much, but to modification, you they don't help piece of the he had the brown osteotomy, which is more distal for a relatively lower hallux valgus angle with a nearly normal intermetatarsal angle. Then you have scarf osteotomy, which is a Z-shaped osteotomy of the metatarsal shaft, or a proximal base Ludlow osteotomy. So proximal phalanx osteotomy is generally the Akin osteotomy, which is done in cases of hallux valgus interphalangeus, or in cases with severe hallux valgus deformity when you are using an Akin just to realign the foot slightly better. And then the last one is the first MTPJ fusion in cases of rheumatoid arthritis, or in cases of revision surgery or presence of osteoarthritis already, or a Lapidus fusion, which is fusion of the first tarsometatarsal joint, which is also done in severe hallux valgus cases, as well as in cases which basically involve so either severe hallux valgus case, or cases they have tarsometatarsal hypermobility. So that's about the first talk. So the answer in this case is hallux valgus, with the treatment option being Akin osteotomy. As I said, it is not the ideal option. Ideal option would have been a metatarsal osteotomy. The second one is a patient with ankle injury present with following X-ray. On examination, there is no effusion and anterior ankle joint line tenderness is present. What is false regarding the diagnosis? And so you can see there is an X-ray in which you can see that the medial cleared space is actually increased, and there is a lateral shifting of the talus out of the ankle mortise. There is some increase in the tibiofibular clear space, while the overlap is still there. This overlap, but if you look at it, it is not exactly a mortise view. It is more of an AP view, because there is some overlap in the talar dome as well as the fibula. So the options are: on AP view, tibiofibular cleared space more than 6 millimeters indicates syndesmotic injury. Weight bearing stress X-ray guides the management. Tear of deltoid ligament along with AITFL, which is the syndesmotic anterior ligament, is an indication for surgery. And on mortise view, a tibiofibular overlap less than 6 millimeters indicates an unstable injury. So we just talk about one by one. So weight bearing. So we'll talk about this in another slide about all the angulation. I think tear of deltoid ligament along with AITFL is an indication for surgery. If it is an unstable joint and AITFL is torn and deltoid ligament is torn, like in this case, then definitely that is an indication of surgery, because you have to restore ankle mortise. So weight bearing stress X-ray guides the management. So what are the stress X-rays that you're doing to check for syndesmotic instability? So this picture, if you see, it is basically a gravity-based stress X-ray, in which what you're doing is you're just asking the patient to external rotate the foot. So over here, you can see the proximal aspect is actually supported by a stool over here. The patient, it is more of an AP view, but the patient is externally rotated so that the fibula is down and the gravity is giving the stress. So gravity stress test is one of the ways of you can check syndesmotic instability. Similarly, you can do an external rotation stress test, and the third one is a weight bearing stress test. So all of these are there. Then the second thing is with regards to the overlap and the clear space. So this is an AP. This is the mortise view, and you can see that the overlap is more in the AP view as compared to the mortise view, and clear space is roughly the same. So a typical clear space less than 6 millimeter on AP and mortise view suggest that this is normal, and more than 6 millimeters suggests a syndesmotic instability. When we talk about AP view, a tibiofibular overlap more than 6 millimeter is what is normal. So a less than 6 millimeter tibiofibular overlap, but on the AP view would suggest a syndesmotic instability. And a tibiofibular overlap which is more than 1 millimeter on mortise view. So if you look at the mortise view, it should be more than 1 millimeter. In AP view, it should be more than 6 millimeters. So which means that a syndesmotic instability or injury may be suspected if the tibiofibular overlap is less than 6 millimeter on AP view and it is less than 1 millimeter on mortise view. And we come to the option. So in this view, it is written on mortise view, tibiofibular overlap less than 6 millimeter indicates unstable injury. So finally, the answer is this one, because it is less than 1 millimeter